So a very good evening, my dear students, a very good evening. So here we are for the discussion of the grand test INICT power grand test number 4. So I hope you've attempted the questions, and this time I have got a different set of questions for you. Some concepts that are going to be clear to you that probably you would not have come across. So let us begin with the first question. So the first question is, in a child patient, which of the following is not given for a daycare treatment? Okay, so which of the following drugs is not given for a daycare treatment in case of a child patient? So the answer here is B, that is halothane. Okay, so now in order for you to remember the basic daycare surgery drugs, I have got a mnemonic here. So the trick for the daycare surgery is the mnemonic goes something like this. So say Dr. Manmohan Singh is a prime minister. So this mnemonic is not being made by me. It's a very old mnemonic. So this is basically the trick for the daycare surgery drugs that can be used in a child. Okay, so what are these daycare surgery drugs? So with D begins desflurane, M stands for midazolam, S stands for sevoflurane, I stands for isoflurane, then we have A, that stands for alfentanil, then we have P, that stands for propofol, and then M stands for mivacurium. So these are basically the drugs that can be used for a daycare surgery in case of children. So in the options that are given, the options given are propofol. So yes, propofol can be, propofol is a daycare surgery drug. Then the option B that is given is halothane. So halothane is not present in this list of drugs. Then option C says desflurane. So yes, desflurane is another drug that can be used for a daycare surgery, and option D is sevoflurane. So sevoflurane is also in the list of the daycare surgery drugs. So this is the mnemonic, and these are the drugs that can be used for daycare surgery. Please note them down. A question like this can be asked, so this mnemonic is going to come handy. Okay, now also when we are talking about the daycare surgery, just randomly I want you all to know the color coding of the cylinders that are used for storing various gases in the operation theater. So what are the color coding? So if there is air in a cylinder, the color code of the cylinder is going to be a grey body with white shoulder. So that's going to be a grey body, white shoulder. Oxygen is contained in a cylinder that is black in color. So it has a black body and white shoulder. If there is, say, carbon dioxide in a cylinder, then it is going to be grey in color. Then if there is if there is helium in a cylinder, then the color of the cylinder is going to be brown. Then if there is nitrous oxide, then the cylinder is going to be blue. So we've read nitrous oxide gas in case of inhalational sedation, conscious sedation. So the cylinder that contains nitrous oxide is blue in color. In case there is cyclopropane, the color code of the cylinder will be orange. If there is N2NOx in it, then it is going to be blue body and white shoulder. So this is the color coding of the various gas cylinders that are used. Now, some more facts that I want you all to know is IV anesthetic of choice in children is always ketamine. So the IV anesthetic of choice is ketamine. IV anesthetic of choice. Okay, inhalational anesthesia of choice in children is sevoflurane. So sevoflurane is the inhalational anesthesia of choice. Okay, then the best in intravenous agent for daycare surgery is propofol, and the best inhalational agent for daycare anesthesia is desflurane. But in India, if it is specifically asked in a question, then isoflurane is used as an alternative because of the cost effectiveness of it. Okay, so the best combination is considered to be propofol and alfentanil, and the combination that is mostly used in India is propofol and fentanyl. Okay, so that makes up for the first question in where it was asked, in child patient which of the following is not given for daycare treatment. So the answer here is halothane. The second question that is being asked is, which stage of ECC is present in the following image? So whether it is mild or very mild, or it is moderate, or it is severe. So you all can see that the lesions have not completely destroyed the incisors. Neither are the lower incisors involved. Okay. Right, so the answer here, so obviously it is not mild because there is discoloration on the surface of the tooth. Okay, there is a little cavitation, destruction of the surface of the tooth that can be seen. So it is not mild or very mild, neither it is severe because gross destruction it is not seen, and involvement of lower incisors is not seen. So it is not severe. So the answer undoubtedly becomes moderate. So the answer here is C, that is moderate. So the American Academy of Pediatric Dentistry defines early childhood caries as the presence of one or more decade, that is whether it is cavitated or non-cavitated, missing, that is due to caries, or filled tooth surfaces in any primary tooth in a child 71 months of age or younger. So that is the definition that is given by AAPD of the early childhood caries. So it is most common chronic disease that is present in children, and it is seen as a white spot. So white spot is the initial lesion. Right, on the front teeth. Further it develops into a yellow, brown and black area, and ultimately there is crown fracture due to lack of the tooth structure. In children who are younger than 3 years of age, any sign of smooth surface caries is indicative of severe early childhood caries. So if at the smooth surface caries there is sign of deep caries, that means it is a severe early childhood caries. Now what is the cause of ECC after the eruption of the primary teeth begins? So excessive or frequent bottle feeding and or prolonged bottle feeding or breastfeeding. So basically at will bottle feeding or breastfeeding and excessive frequency is going to result in causing ECC in children. Now what is the pattern? So typically it follows a definite pattern. So what is the pattern that the ECC follows? So there is early carious involvement of the maxillary teeth. So early carious involvement of the maxillary teeth, the maxillary and the mandibular first primary molars. Then it comes to the maxillary and mandibular first primary molars. And sometimes it will involve the mandibular canines also. But mostly the mandibular incisors usually remain unaffected. So why? Because they are considered as the immune teeth of the oral cavity, because they are in contact with the tongue, so the cleansing action of the tongue, continuous cleansing action, and the presence of lingual salivary glands results in continuous flushing of the debris that get deposited in and around the mandibular incisors, and that is why caries in mandibular incisors is uncommon, only if it is unless it is a severe case. So this is the progress that happens. This is the early decay, this is the moderate decay, and this is the advanced decay. Okay. So that brings us to the next question, that is a 7-year-old child having very deep carious lesions in multiple teeth with no pain. Okay. So there are deep carious lesions with no pain. What should be the treatment plan? So since there is no pain, so no pain indicates one particular thing, that the pulp is not inflamed. So there is no irreversible pulpitis that has happened. So the pulp is not inflamed, and that there is no point in doing extraction, because the pulp is healthy. Why will you extract the teeth? RCT of all the teeth. So RCT, you do not have to do RCT pulpectomy because the pulp is not involved. Again, when the pulp is not involved, why will you touch or approach the pulp? So the most a sensible thing to do is to protect the pulp of the teeth by indirect pulp capping. If there is no pain at all, then you must try to not irritate the pulp, not deliberately inflame the pulp. So you do what? You do an indirect pulp capping. So the answer here is A, indirect pulp capping, only because of the fact that they have mentioned that there is no pain. Okay. So indirect pulp treatment is a procedure performed in a tooth with deep carious lesions approximating the pulp. So the lesions that are close to pulp but not involving pulp. Okay, so in these cases what you do, and then again there are no signs and symptoms of pulp degeneration or pulp inflammation. So the caries surrounding the pulp, a small part of the active caries is left in place to avoid pulp exposure, and it is covered with a biocompatible material. The indirect pulp capping has been shown to have higher success rate than pulpotomy. So a lot of times your indirect pulp capping will work wonders, whereas if you do pulpotomy in primary teeth, there are a lot of chances that your radicular pulp will get inflamed as well, and you will have to proceed with the process of pulpectomy. So it is always better to let the pulp heal until and unless you can, if it is not inflamed. Okay. Now it also follows a normal exfoliation time. So it will follow a normal exfoliation time if you've just done an indirect pulp capping. Therefore, indirect pulp treatment is preferable to pulpotomy when the pulp is normal or has a diagnosis of reversible pulpitis and not irreversible pulpitis. So this is a case of reversible pulpitis, and since there is no pain, it is not an irreversible pulpitis. That brings us to the fourth question, that is, A 7-year girl with single tooth crossbite came to the clinic, and what should be the treatment plan? So you all know what is a crossbite. So generally your maxillary teeth should be overlapping the mandibular teeth, but if your mandibular teeth are overlapping the maxillary teeth, then it is called as a crossbite. So single tooth crossbite, that means only one maxillary tooth is present inside and the mandibular tooth is covering it from outside. That is a single crossbite case. So in this, what you will do, the options given are: wait till all the permanent teeth erupt. So you cannot wait till all the permanent teeth are erupting, okay, because you have to do an early action to prevent the developing crossbite. So pay attention that they've mentioned a 7-year-old girl here. That means single tooth crossbite, that means it must be a permanent incisor. It is developing into a single tooth crossbite, so it must be a permanent incisor which is still developing or erupting. Okay, so wait till all the permanent teeth erupt. So no, that's not a good option. Then removable appliance therapy. So let's keep this option aside. Then we have immediate interventional therapy. Let's keep this aside as well. And extraction of the tooth. Why will you extract the tooth? It's just a crossbite. So now when we compare B and C, so since it is a 7-year-old girl, you have to take in consideration the fact that the tooth is partially erupted. So when it is a 7-year-old girl, the tooth might not have been completely erupted because the eruption ranges from 6 to 8 years. Okay, so you have to consider that probably the tooth might be partially erupted. So when it is partially erupted, just straight away giving a removable appliance might not work. The removable appliance generally that is used to correct a single tooth crossbite incorporates a Z spring. So for a Z spring to be active, the arm of the Z spring that causes the movement should fully rest on the lingual side of an erupted tooth. So if in this particular girl, if the tooth is partially erupted, the Z spring arm will not rest on the tooth and the action will not be possible. So removable appliance therapy is not a 100% sure shot solution. So the answer here becomes immediate intervention therapy. So I'm going to tell you what is it about. So localized dentoalveolar crossbite without or with mandibular displacement should be corrected as soon as it is discovered. Like if the mandibular incisors permanent have erupted and now the maxillary permanent incisor is erupting and it has erupted only halfway and you can see that it is already in crossbite. Do not wait for do not wait for it to completely erupt. You can immediately intervene. Delayed treatment can lead to serious complications. So what complications can it lead to? So it can lead to loss of arch dimensions. It can also lead to asymmetric midlines. It can cause traumatic occlusions. Okay, then it can also lead to stripping of the gingival tissue on the labial surface of the lower teeth, because the upper teeth will rest on the gingival tissue of the lower teeth. So it might result in trauma to gingival tissue of lower teeth. Then it can also lead to wear facets on involved incisors. So it can lead to wear facets on the involved incisors. And it can cause functional shift also. That means functional shift of the growth pattern. So it can also result in functional shift of growth patterns. So if a single tooth crossbite is also not attended, then so many complications, so many problems can be created. Now the various treatment modalities. So when I say immediate intervention or immediate interventional therapy, so when I say immediate intervention, so there are various methods by which the treatment can be done. So the various modalities that have been proposed to correct the anterior dental crossbite are: number 1, tongue blade; number 2, reverse stainless steel crowns. So I'm going to show you the picture. So reverse stainless steel crowns. Then we have fixed acrylic plates, or fixed acrylic planes. So these are anterior bite planes. Then there can be bonded resin composite slopes. And then there are removable acrylic appliances incorporating Z springs. So removable appliance. So removable appliance can be used, but let's keep it as an option as and when the situation suggests. So if the tooth is completely erupted and the tooth has area where the arm of the Z spring can rest, then it is then it will be then you can use the removable appliance. Otherwise there are so many other options. So let's look at the picture of all of these. So this is a tongue blade, or this is the tongue blade therapy. Okay, so tongue blade is nothing but an ice cream stick. So you have the ice cream stick, right, on which your chocobar, or you'll have that wooden spoon that you get with the ice cream. So that stick is taken and you train the patient to hold the stick such that the one end of the stick goes under the maxillary tooth and the other end goes over the mandibular tooth. So the maxillary tooth has a slope to grow on and grows outwards. So can you see it in the picture how the tongue blade therapy can work? How is it done? Again, the reverse stainless steel crown, that means a reverse stainless steel crown is given on the upper tooth. Reverse, that means the cingulum area comes outside and the labial plane comes inside. So when such is the arrangement, what happens? The tooth can slide outwards over the labial plane and the tooth grows in that fashion, that is, it comes out of the cross bite. Then we have fixed acrylic plane. So that means it is like this. It is a anterior inclined plane. So this anterior inclined plane opens the bite and the slope is like that. It slopes towards the front so that the growing incisor comes in front. It grows on the slope so that it comes on the front of the mandibular teeth. Okay, then we have this, that is the bonded resin composite slopes. So nothing, you just take your composite material and you place it on the lower or the mandibular teeth, and you place it so that you place the composite such that there is a slope made that is coming forward. So that is a bonded resin composite slope. Then we have a removable appliance that incorporates a Z spring. So it basically looks like this. I think in this picture it is clearer. Okay, so these are all the retentive arms. These are the retentive arms, okay, and this is the Z spring. So this Z spring, the arm will rest on the lingual surface of the incisor, and there is a loop over here. So when you activate the loop, this arm will push the incisor forwards, and this particular part of the acrylic will keep the bite open a little. So every time you call the patient, you activate the loop and increase the force that the arm is applying on the tooth so that the tooth moves forward. So this is a corrected case. Can you all see? This is the appliance that is given, and here in this both the teeth have come at the same level. Here it was in a cross bite. So just compare both these cases. So here the tooth was in a crossbite. Can you all see? Okay, I hid it. Yeah, so it is in a crossbite. Eventually in this picture it has come in the same level. The crossbite is corrected. So these are the various therapies, or these are the various interventions that can be done in order to correct a single crossbite. And I told you why is it important to correct the single crossbite. It has the various complications that we just read. This brings us to the fifth question, which is, which of the following or which of these is not used for obturation of the carious deciduous molars after pulpectomy? Okay, so when we are talking about the obturating materials that are used in the deciduous molars, rest all is okay. It should be biocompatible, it should be radio opaque, it should be sterile, it should be everything. But the most important point for an obturating material that can be used in a deciduous molar, deciduous tooth, is that it should be resorbable. So the material should be able to resorb itself on its own, okay, because the deciduous tooth is resorbing with time. There is physiological resorption that is occurring in a deciduous tooth. So it resorbs with time, and the material that you use to obturate it should also have the capacity to resorb. Okay, so now the options that are given, the zinc oxide eugenol is not the answer because it resorbs on itself and it is a very commonly used obturating material. Same is calcium hydroxide plus iodoform, which is available in the form of Metapex. It is also an excellent obturating material. KRI paste is also an excellent material that can be used for obturation. It also resorbs with time. But the only material that does not resorb, that sets into a very, very hard mass and that does not shake, then it just sets into a hard mass, that is MTA. So MTA is non-resorbable, it sets into a hard mass, and hence it can be used in apexification or pulpotomy or direct pulp capping, but it cannot be used as an obturating material in deciduous teeth. So what exactly is MTA? So MTA is mineral trioxide aggregate. So mineral trioxide aggregate, and the most fascinating thing about MTA is that its composition and properties. So the composition and properties are similar to, so the composition and properties are similar to that of Portland cement. Okay, so MTA cannot be used as an obturating material in deciduous teeth, as MTA cement sets into an insoluble, unresorbable solid mass. It does not resorb along with the resorption of the tooth root. It can be used as a pulpotomy agent in primary teeth. So where in the permanent teeth can MTA be used? So MTA in permanent teeth can be used in case of root end filling. It can be used in case of a perforation repair. It can be used for root resorption repair in case of permanent teeth I'm talking, okay? Then it can be used as obturation or obturating material in case of permanent teeth again, okay, and then it can be used as a root canal sealing material also. So these are the various techniques or various procedures in which MTA can be used in case of permanent teeth. So it's an excellent material but not used for obturation in deciduous teeth because of its non-resorbing properties. So that brings us to the sixth question, which is a 5-year-old child has spacing in the teeth. So there are spacing in the teeth. The child is 5-year-old. So when I say 5-year-old, that means how many teeth are present? So 5-year-old, that means we have all primary teeth. No permanent teeth has erupted yet. All primary teeth, that means a total of 20 teeth, that is all primary teeth are present, no permanent teeth. Which of the following is the treatment needed? So there is no need of looking at any other option. The only one answer is no treatment required here. Okay, so there is no treatment required in a 5-year-old for the spacing because the spaces naturally occur in case of primary teeth. So spacing in primary teeth is absolutely normal and desirable feature of primary dentition for normal development of permanent dentition, which doesn't need any treatment. Okay, so that is a naturally occurring phenomena. Absence of these spaces can be an indication of crowding happening in the permanent dentition. So a non-spaced primary dentition, which is by the way also called as a Hollywood smile. So this can also be asked in MCQs. So a non-spaced primary dentition is called as a Hollywood smile. So it is very Hollywoody at the beginning, but it 100% results in crowding in permanent dentition. Right. So the spaces that are present, the naturally occurring spaces, so the spaces in the primary dentition are, so the spaces that naturally occur in the primary dentition are the normal physiological spaces, so normal physiological spaces are the generalized spaces that are present in between all of the teeth. They are just present in all of the teeth. Okay, they are normal physiological spaces. And then we have the primate spaces. So the primate spaces are also known as anthropoid spaces and simian spaces also. Okay, so these are the two types of spaces. So as I told you, the normal physiological spaces are present in between all the teeth, but the primate spaces in the maxilla is present mesial to the primary canine, and in the mandible it is present distal to the primary canine. So here are the primate spaces that are present in the primary teeth. So basically the physiological spaces between mandibular canine and the first primary molar and between the maxillary lateral incisor and the primary canine are known as the primate spaces, and this particular name was given by a person named as Baum. Okay, so this was given by Baum. Okay, so the answer here is these spaces naturally occur in a dentition of a child, and so no treatment is required. So that brings us to the seventh question, and the seventh question is identify the use of the following instrument. So this appears to be a fixed appliance in the maxilla. So this looks like a fixed maxillary appliance. Okay, So this appliance has a Teflon roller present in the anterior region. So this particular thing, the cylindrical part, is a roller that freely moves around the wire, and it is made out of Teflon, and this whole setup or this whole appliance is known as the bluegrass appliance. Okay, so what is this? This is the bluegrass appliance. Right, so the appliance is known as the bluegrass appliance, and the bluegrass appliance was first used by Haskell and Mink. So these two people use the bluegrass appliance for the first time. It is used for positive reinforcement to stop thumb sucking in children. So it is used for eliminating the thumb sucking habit. In children. So what happens? Why is thumb sucking so pleasurable as a habit for children? Because when they put the thumb inside their mouth, they suck the thumb. That means a vacuum or a sucking pressure is created in the mouth. So when this Teflon roller is present, first thing, the vacuum or the suction pressure is not created in the mouth because of that roller. Second, the child will be keep on playing with that particular Teflon roller, and the suction or the the habit of thumb sucking will eventually come to an end. So it is indicated for children who continue a thumb sucking habit, which can affect the mixed and permanent dentition. So the answer here is, it is the following instrument is a bluegrass appliance, and it is used as a therapy for thumb sucking. So the answer here is B, that is thumb sucking. So that brings us to the 8th question, which is a 2-year-old child visiting a dental clinic. So the child is 2-year-old. He is visiting the dental clinic for the first time. Has a fear of the white coat. So he has a fear of the white coat. So what is this due to? So which theory is applicable here? Okay, that fear of white coat is being due to which type of a theory, or which theory is applicable over here? So the theory that is applicable here is C, that is classical conditioning theory. So the answer is C, that is classical conditioning theory. So the classical conditioning theory was given by Ivan Pavlov. So this theory was given by Ivan Pavlov. This theory was given by Ivan Pavlov, and this process involves the following steps. So the classical conditioning theory involves will involve the following steps. Okay, so what steps are involved? The first is acquisition. Okay, so there is acquisition, there is generalization, there is discrimination, and then there is extinction. So these are the steps of the classical conditioning theory. So acquisition means to acquire a particular knowledge, like to learn something new. Generalization means to generalize that newly found information to everything that is similar. Discrimination is again attaining some new knowledge and to be able to discriminate the different knowledge with different people. And extinction means complete disappearance of the fear that has been acquired earlier. So let me explain you all of these 4 steps based on the white coat fear. So for example, a child went to a dental clinic and he saw that the dentist is wearing a white coat, a white apron, and he's really hurting people, he's giving injection to the people and he's running a very scary drill in the mouth of the people. So the child acquired a new information that a person with white coat is causing pain to other people. So the child will generalize this information. So the child is going to generalize this information to everybody who's wearing a white coat. Any other dentist or any other doctor wearing a white apron, he has generalized it that he will also cause pain, he will also cause pain, he will also cause pain. Now one fine day he goes to a different dentist, and the dentist just sits with him, shows him different pictures of funny cartoons getting teeth treated, and just talks, just uses a mouth mirror, does not use anything. He's very happy, smiling and friendly. So the child has learned to discriminate that okay, that dentist was not friendly, he was hurting people. This dentist is very friendly, he's not hurting anybody. So this is called as discrimination. And then extinction, that means complete extinction of the fear, white coat fear. Now he's not generalizing it, the fear has become extinct. Okay. So again, the white coat is a natural stimulus which has generated an unconditioned stimulus, that is pain of injection. The pain of injection is an unconditioned stimulus that generates a response which is fear and crying. In the second visit, a sight of white coat will become a conditioned stimulus which will generate a response of fear and crying. So that is what is actually happening, and that is the classical conditioning theory that was given by Ivan Pavlov. You remember the dog experiment? That was Ivan Pavlov's experiment. Now let us hop on to the 9th question, which is a white spot seen on 5-1. So when I say 5-1, that means here I am talking about the primary central incisor in a 4-year-old child. So this is a 4-year-old child they are talking about. The treatment required is, what is the treatment required? It's a white spot lesion. So the answer here is just enhance remineralization. It is just a white spot lesion, so there is no need of restoring with GIC, no need of crown obviously. Let it be as it is. Why? You are seeing a white spot lesion. So just go for enhancing the remineralization. So how can you do that? So basically a white spot lesion on the tooth is the earliest clinical sign of the caries. So white spot is so what is a white spot? It is an initial carious lesion. So it is an initial carious lesion. So it is the earliest clinical sign of the caries process on smooth surface enamel, usually seen under a layer of plaque at the gingival margin of tooth surfaces. Okay, so where is it usually seen? It is seen under a layer of plaque at the gingival margin of tooth surfaces. Okay, here it is seen. The use of fluoride in its various forms improves the oral hygiene, and dietary control are primarily effective in combating the smooth surface lesions and causing enhancement of remineralization. With intact surface layer of white spot, remineralization of the lesions is possible and a restoration can be avoided. So you use a fluoridated toothpaste, you have better fluoride containing food materials, and you basically enhance the remineralization process instead of doing a restoration. Okay, so that gets us to the 10th question, which is Clark's method of calculating drug dose in pediatric patients is based on what? Okay, so Clark's method, they've asked, so Clark's method of calculating the drug dosage, so it is based on body weight. So the answer here is body weight. Clark's method is based on body weight. So basically the Clark's method is so the drug dosage by Clark's method is So weight of the child in pounds, okay, multiplied by adult dose divided by 150 is equal to the child dose. So it is using the body weight. Okay, so you must also know there is a Young's method of calculation and the Young, so this is the Clark's method. Okay, then the Young's method of drug dose calculation. So this uses the age of the child. So this formula is child age in years multiplied by adult dose divided by child age plus 12 is equal to the child dose. So this is the Young's method. So that's the Clark method and this is the Young method. Body surface area though is the most accurate method of calculating the dose in the pediatric patients. So you must know what the Clark's methods used and what the Young's formula, the Young's method uses for calculation of the drug dose in a child. So Clark's method, the answer is body weight. Now comes the 11th question, which is the primary maxillary teeth erupt in which of the following pattern. So this particular thing that they've given is, this is the universal method of a tooth numbering system. So when we see the tooth numbering system, so we have three types of tooth numbering systems. One is universal method, one is FDI method, and one is Zsigmondy-Palmer method. Okay, so when we say universal, so in universal we can denote the primary dentition by this particular, so we can say A, B, A, B, C, D, E. So this is not universal method, I'm sorry. C, D, E, F, G, H, I, J, K, L, M, N, O, P, Q, R, S, T. So this is how the primary is denoted in the universal method. In the FDI, the primary is denoted something like this. So this is the primary teeth in the FDI. It is 5-1, 5-2, 5-3, 5-4 and 5-5. Here we have 6-1, 7-1, 8-1. So this is how it is denoted. So 6-1 to 6-5, 7-1 to 7-5, 8-1 to 8-5. Whereas in the Zsigmondy-Palmer method, the primary is denoted like this. A, B, C, D, E, A, B, C, D, E, A, B, C, D, E and A, B, C, D, E. And the permanent is denoted like 1, 2, 3, 4, 5, 6. Same here, same here, same here. Okay, so this is how we denote it in the Zsigmondy-Palmer method. So what they have mentioned here is the Zsigmondy-Palmer method of tooth numbering system. So obviously A will stand for the primary central incisor, B stands for the primary lateral incisor, C stands for primary canine, D stands for primary first molar and E stands for the primary second molar. So what is the pattern of eruption? So the pattern of eruption is A, B, D, C, E. So that is the correct pattern of eruption. First the central incisor erupts, then the lateral incisor erupts, then erupts the first primary molar, then the canine, and then the second primary molar. So the answer here is A, B, D, C, E, that is B. Option number B is the correct answer over here. Okay, so when we look at the permanent sequence, so the most common sequence of eruption in the maxilla in the permanent teeth is, so in case of maxilla, in permanent teeth is 6, 1, 2, 6, 1, 2, 4, 3, 5, 7, 8, and in case of the mandible, it is 6, 1, so it can, either of them can erupt first, 2, 3, 4, 5, 7, 8. Okay, so these are the eruption sequence of the primary and the permanent teeth. So these are the correct eruption sequence. So just note them down. The answer here is B, that is A, B, D, C, E. So that brings us to the last question of today's discussion, which is, object permanence is seen in which stage of Jean Piaget's theory? Okay, so object permanence means when a child is very, very small, he does not have the sense of object permanence, which is what? The sense of feeling that if something is out of sight, it still exists. What he thinks is, if something is out of sight, it does not exist at all. Okay, so this object permanence develops in the sensory motor stage of Jean Piaget. So Jean Piaget gave these 4 stages, and these 4 stages are basically, the sensory motor stage is the stage when the child is 0 to 2 years of age. In this, the object permanence phenomena develops. The pre-operational stage is when the child is 2 to 7 years of age. The concrete operational is when the child is 7 to 11 years of age. And the formal operational is when the child is 12 years to adulthood. So these are the stages that were given by Jean Piaget, and how differently the mental development happens in these stages. It's been beautifully told in the theory. Go through the theory. The object permanence specifically develops in the sensory motor stage. Do not get confused between the sensory motor and the pre-operational stage. The answer is A, sensory motor. Go through this theory. I have explained it completely during my class, and if there are any doubts in the questions that I discussed today, please get to me with the doubts, and I am going to solve all the doubts. So here we've completed the discussion of the 12 questions that I had brought for you. I hope you gained something extra with these questions, and thank you so much for today. A very, very good night to you all.